Good afternoon. My name is Yngvild Olsen, and I'm going to be the last speaker in our panel, and then we'll turn to some questions and discussion, hopefully. And I really wanted to just say thank you for the opportunity to participate in really this important effort that you all have undertaken. I spend most of my week as a clinician in an opioid treatment program. Comprehensively, we provide all three of the FDA-approved medications for the treatment of opioid use disorder, and a lot of kind of what I've already heard today resonates very well with the work that I do directly with individual patients. I have a few slides, not quite as many as maybe some others, that I'm going to use to frame my remarks, and then really look forward to the questions and discussion. So you've already heard today about some of the interventions that have been intended to reduce the incidence of opiate use disorder, ways to reduce the mortality from opioids, and I was asked to address the third leg of this issue, so namely the state of the science since 2011 for opioid agonists to treat opiate addiction. And I'm going to add in some of my other thoughts in here as well. So I'm not going to actually review all the evidence because that would take a lot longer. But in doing so, I really wanted to highlight kind of some of the issues that relate to treatment and recovery support services, because we've talked about kind of the overdose response program to decrease mortality, the prevention, various different prevention strategies to decrease the incidence of opioid use disorder. But what do we do about the millions of people now who have a substance use disorder? And in doing that, I think it's critically important to recognize some key aspects from the literature and lessons that we've learned from decades of clinical experience with this disease. That addiction is a multifaceted disease that affects all aspects of an individual's life. And as such, effective intervention needs to pay attention to all of those different areas as well. And so many of the social determinants of health, such as housing, poverty, transportation, they also impact not just the presentation and the scope of the disease itself, but they also impact the effectiveness of treatment. So we really need to be able to address those in our policies. So, and as a primary chronic brain disease, there is no cure for addiction. There have been efforts since in the early 1900s, in fact, to actually find that miracle cure. And unfortunately that failed, and if that's what we're looking for, we're going to fail again. Addiction has been around for millennia, so the idea that somehow we're going to eradicate it is a great, I would love to do that. I would love to be out of a job, but unfortunately I think that the chances of getting there are very slim to none. So rather, the goal is really lifelong management, with remission and recovery defining that goal. And that goal is coupled with the understanding that the severity of the disease can vary over time, with decreasing risks of recurrence, but we now have some data that it takes about 3 to 5 years of sustained recovery before the risk of relapse drops below 15%, and it never goes to zero. And finally, we have some good data that retention in treatment has been shown to be the best predictor of recovery. And with only about 50% of individuals with opiate use disorder staying in care past a year, identifying and supporting ways to better engage and keep people in treatment needs to be a key focus. And increasingly, there is also a recognition that this model of a multifaceted disease condition that responds best to multifaceted interventions also can apply to chronic pain, as you see in this slide here. And that is especially true for the upwards of 40% of patients with an addiction who also have chronic pain. And for those individuals, inadequately treated pain can be a significant risk factor for relapse. So at this point in 2016, we have seen the approval of injectable naltrexone for the prevention of relapse to opiate use disorder. That happened in 2010. And so we now have 3 medications available for the treatment of opioid addiction. Methadone at the top as a full agonist opioid. That's been around since the 1960s for this indication. Buprenorphine as a partial opioid agonist that was FDA approved in 2002. And then the complete opioid antagonist, naltrexone, approved, as I said, in 2010. And in addition, since 2011, there's also been the introduction and approval of several different formulations of buprenorphine, including a couple of different sublingual formulations, a buccal formulation, and most recently this summer, an implantable formulation of a low-dose form of buprenorphine that lasts for about 6 months before it needs to be taken out and replaced. And the evidence base that we have has shown that all 3 of these medications are effective compared with particularly placebo and interventions that do not include the medication, and that they all reduce the use of illicit opioids by about 40 to 70, 80%, that they reduce the transmission of HIV, hepatitis C, hepatitis B, they increase rates of employment, decrease rates of crime, increase longevity of life, quality of life. And from one of the studies that we did in Baltimore with respect to the Baltimore Buprenorphine Initiative, the expansion of access to opiate agonist-based therapies was also able to reduce mortality from opioids, particularly heroin. So over a 10-year period, we saw that the expansion of access to these medications led to 10 fewer deaths per year in that city. But despite those advances, we still have a very large treatment gap of over 1 million people. That's some data from the CDC, and that actually assumes that everyone who has their waiver, the physicians who are now approved by the or have the qualifications set out in Data 2000 to prescribe buprenorphine in their offices for the treatment of opiate use disorder, if all of those physicians prescribe to their max, so either 30 patients or 100 patients, we still would have a treatment gap of over 1 million people. And with the increases in heroin and fentanyl exposure that we've heard about, now more than ever, we really need as many tools as possible in the toolbox. And while that may mean having the FDA and other federal agencies invest more resources into identifying alternatives to opioids for chronic pain management, incentivizing the development of additional pharmacotherapies for the treatment of opioid use disorder, it also, to me, means adopting strategies and conducting research to maximize the tools that we currently have available. Since we know, not just with naltrexone or naloxone for the reversal of opioid overdoses, but for the treatment, there's a significant underutilization. And we know, for example, that inadequate insurance coverage, physician stigma and fear, some of these things have come up already, and public stigma against agonist therapy for opiate addiction significantly limits access to these therapies for many people in many parts of the country. And we also know from the National Survey on Drug Use and Health data that large numbers of individuals with substance use disorders do not feel they need treatment. And for many in that group, rigid treatment models that are based in kind of the old punitive approach to addiction do nothing to make treatment inviting or something to be considered as helpful. And so integrating low threshold entry into treatment of opiate addiction, as is done in many other countries, may help actually alleviate that. And there's some studied models, both out of Baltimore and other places, Yale, of medical therapies that are offered in other other clinical settings and even non-clinical settings, such as emergency departments, hospitals, non-addiction medical specialty and primary care settings, through community pharmacies, in prisons and detention centers, that can serve to support the engagement in more comprehensive treatment, reduce overdose and other harms from opiate addiction. And in addition, and then I'm going to get to the slide, for individuals who have both opiate addiction and chronic pain, our system actually has created an artificial distinction between their treatments with opioid agonists. For example, buprenorphine patches, Butrans, they're FDA approved for pain only, but they cannot be used off-label for opiate use disorder, partly as a result of the Controlled Substances Act of 1970. Methadone in an opioid treatment program can be used for opiate use disorder, but not pain management primarily. And methadone that is prescribed for the treatment of pain in an office-based setting cannot be used off-label for the treatment of opiate use disorder. Sublingual buprenorphine is approved for the treatment of opiate use disorder, can be used off-label for pain, but doesn't have a primary pain management indication. So that has created a number of barriers and confusion, really, for effective and accessible treatment of both conditions. So the question also that continues to be asked is, which medical therapy for opiate addiction is the most effective? And I hear that being asked by family members, my patients, in the halls of legislatures, both at the state level and in Congress, by payers, by other healthcare practitioners. And even within the field of addiction medicine, that question is sometimes hotly debated. And some may interpret that question as indicating a need for comparative effectiveness research with the available medications that we have. However, to me, that question actually makes assumptions that I believe have not been adequately tested and need further research. And so one such assumption is that there is one-size-fits-all medication. And we know that nowhere in medicine is that actually true. But unfortunately, the research to date does not take into account sufficiently the different severities of opiate use disorder. So somebody had already asked earlier in the other panel had asked about the switch from DSM-4 to DSM-5. I really personally like that switch because it does allow for a distinction between mild, moderate, and severe forms of the disorder based on the number of clinical criteria that someone meets. And clinically, we're beginning to recognize different subtypes of opioid use disorder that really, in my mind, have not been well characterized and that may impact the response to these various different medication. And that heterogeneity of opiate addiction is likely related to the body of risk factors that I've outlined here in this wonderful NIDA slide for the development of substance use disorders, including the genetic component that accounts for about 40 to 60% of the risk. Now, research has been done, and it continues to be done, to better elucidate not only the genetic variances that are involved, but also their functional significance. And in fact, there's pharmacogenomic studies going on to actually even try and identify the various different responses that people may have based on their genetics to the number of different medications that we have. And that research needs appropriate level of funding, and findings from that work need to be quickly translated into practical applications and incorporated into improved training on addiction and chronic pain throughout the medical and other healthcare professional arenas. And so finally, I wanted to end with a comment about language. Because unfortunately, the language and terminology that most often is heard and used in conversations and discussion on addiction, and for that matter, chronic pain, is really still rooted in the old belief that addiction is a moral failure or a result of poor choices by badly behaving people. And that lexicon, unfortunately, perpetuates that stigma of addiction and undermines efforts of preventing and treating the disease effectively. So I'd like to leave you with a different framework that SAMHSA actually rolled out over a decade ago, but that to me has kind of gotten lost a little bit in the steam of this opioid epidemic. And that's really, it's a recovery-oriented system of care that I think is worth returning to in a significant way as we look down the road long-term of a systemic response to the opioid epidemic, as well as the problem of chronic pain. Because it really puts the person at the center, flips around and says, you know, what are the strengths that people bring into treatment instead of their weaknesses? It involves all family and other allies so that they understand what treatment is about and what the goals are. And it's individualized, anchored in the community, using peers and the voices of people who have lived experience. And it fits this chronic, long-term nature of the disorder in a much, much, much better way than our acute care model of disease, where we're kind of still stuck. We've made some progress, but we really need to give that kind of our all. So I'm going to stop there, and thank you.